All right, let's talk about atrial fibrillation, a little bit about atrial flutter too. And the first question is really rate control versus just, or changing the rhythm, converting the rhythm. What do you guys want to do? Do you like to go in there and just say, well, you got a heart rate, of 160, and it's atrial fibrillation with an uncontrolled ventricular response, and let's give some medicine and let's slow it down? Or would you rather get in there and cardiovert them? We're emergency physicians. What do you want to do? I guess there are some of us that are conservative that just don't have the sphincter tone to handle going in there and watching a perfusing patient get cardioverted and thinking you might exchange this rhythm for something worse. But really, this is kind of what we're about. And in select patients, this is the right thing to do. And if we do cardiovert them, either chemically or more likely electrically, well, then they can oftentimes go home from the emergency department if it's a Nuanced set and they don't have any other issues. Oftentimes, too, you get patients that come back with a recurrent episode. A recurrent episode, they know they have the same symptoms. They said that the symptoms started, just a few hours ago. Why do they need to have another hospitalization to decide why they're having idiopathic intermittent atrial fibrillation? They don't. But if you put them on Cardioversion and put them in the hospital in order to convert them over to their oral dose, it's going to take a few days. Even though when you achieve rate control with Deltazon, what you should do right then and there, if they're going to use oral Deltazon to maintain their rate control, is start it right in the ED. If you start it at that point, about 6 to 8 hours later, they probably could go home. But we oftentimes don't do that. Let's talk about some of these abstracts. Remember, the big article came out in 2002 in New England Journal of Medicine. It was the AFFIRM trial that said, listen, we don't need to convert this. They're probably not going to stay converted anyway. It's better for everyone involved if we just anticoagulate these patients with a great medicine called Coumadin and just control their rhythm or their rate and not worry about the rhythm. We'll just keep them in atrial fib. And that's what we've done for years. But now, these abstracts that we're going to go through, and there's several of them, really speak to the opposite side of this story and say maybe there are some patients where we can do what we like to do best, make them feel better and send them home. So abstract number 1, management of nuanced atrial fib in previously well patients less than 60 years of age, so they're implying they're healthier. 52 patients, not huge numbers. First episode of AFib, they did a lot of diagnostics. None of them were any value except an echo, which was done in 73% of the patients, and they found half of those patients had an abnormality. And the big thing we'd be looking for there would be mural thrombi. Hey, maybe you've had this longer than you thought you had. And the other would be, do you have a significantly dilated right or left atrium? If your right atrium is significantly dilated, you're not going to stay in a sinus rhythm even if we cardiovert you chemically or electrically. It's just not going to happen. Rate control was achieved in 85%, and this is not that long ago, 2005. What drug do you think they used? I mean, it's back in the time before penicillin, I think, where they were rubbing rocks together to start fires. They were using DIG. And so, I mean, is DIG a good drug? It's not a great drug for us. It just takes too long for the onset of action, but it does have, I suppose, a very small place. But I was surprised to see that in this abstract. 54% were discharged from the ED with persistent AFib. And that's interesting because most of the time when we control the patient's rate, don't we say, well, pretty much we had to put you on something. We're going to keep you in the hospital. We don't know why you had a rate control issue today. Over half of these patients got sent home, which could change our practice if it were more than 52 patients. But that's something to think about, that it may be reasonable to consider that not all of these who get rate control have to come in. Abstract number 2 is the one it talked about. AFFIRM, 4,060 patients greater than or equal to 65 years, AFib and stroke risk factors, and they're on Coumadin. It randomized for rate control versus rhythm control, and both arms could use medications also. So you could use all kinds of meds. Mostly amiodarone was used. You could use DIG, beta blockers, calcium channel blockers, whatever you liked you could use. And the big issue here was they found that if things didn't work out in one group or the other, for rate control versus rhythm control, they could switch them to the other group later. And the premise of this whole article is they were 2 times more likely to switch from the rhythm control group to the rate control group, saying that, rhythm control just wasn't working out, let's just control the rate. And that was looked at 1 year, 3 years, and 5 years, and they said it was double in all those categories. So it's just better to control the rate and don't deal with the rhythm. And that's largely what this article was based on. Mortality rates were the same, stroke rates were the same, nothing else. And abstract number 3, 522 patients randomized for rate control. Number 1 medication listed was DIG, calcium channel blockers, or beta blockers, or they could have rhythm control with cardioversion. It could be repeated at 6-month intervals and also followed by an antidysrhythmic. If you're going to cardiovert somebody, you thought, well, let's put them on something that might keep them out of atrial fibrillation as well. And those drugs, you know them, they're bad actors: sotalol, flecainide, Rhythmol, and Amiodarone. So if you have to be on one of those drugs, and you're also thinking about being on Coumadin, you need to take whatever vacation it was you were planning on taking pretty quick. I mean, these are bad actors. So they had them on these. They targeted the INR 2 to 3, and mean follow-up was at 2.3 years. And they were in sinus rhythm, 39% of the rhythm control group, and sinus rhythm, 10% of the rate control group. So we could say, wow, well, see, most of them, or more of them, in the rhythm control group, 39%, were actually still in sinus rhythm. But the other group, their goal wasn't to put them into sinus rhythm, but it's still nice, and I think it's better for the patient if they're out of atrial fibrillation. Interestingly enough, the primary endpoints: cardiovascular death, CHF, thromboembolic complications, bleeding, pacer insertions, all kinds of different things. The rate control group was 17.2%. Then the rhythm control group was 22.6%. So you might say, well, this is good data because it affirms what we're doing with the AFFIRM trial, and we really shouldn't be changing the rhythm. But all those adverse effects, almost all of them universally, were from those medicines they were using, not because we converted the rhythm. It was the medicines we had to use, and we know that they cause a lot of problems. All right, abstract number 7, chemical cardioversion, procainamide, remember, a class 1A, Rhythmol, a 1C, Amiodarone, a 3. Those are hard to keep straight, but just to go over it briefly, 1As look at phase 0 and phase 3, 1Cs are phase 3, and a class 3 medicine like Amiodarone, it's phase 3 and really dealing with potassium channels. And if you look at phase 0, that's the rapid depolarization with influx of sodium, and phase 3, rapid repolarization, the calcium channels close and the potassium channels stay open. They gave in this study on any one of these 3 medications, and the rates of conversion were interesting. 68.5% for procainamide, 80.2% for Rhythmol, and 89.1% for Amiodarone. Those don't sound like bad numbers until you get to the control, which was 61.1% in the placebo. So if you did nothing, you did almost as well as procainamide with none of the side effects and none of the cost. So, is this really a good way to do things, chemical cardioversion? It's not a great way to do things. And they noted here in this citation as well that a normal left atrial size was the best predictor of prolonged conversion. And we know that. You dilate your atria and you're not going to stay in sinus rhythm very long. I was surprised to see, too, that there were no proarrhythmic events that they noted during this time frame. On those medicines, that's likely to happen. Okay, abstract 8, flecainide versus procainamide, AFib, and they had paroxysmal AFib. So what does that mean for us? It's just not sustained. They're in and out all the time. So it's intermittent AFib, 80 patients, conversion at 1 hour, 93% with flecainide versus 63% with procainamide. Well, they didn't state this here, but I don't know if any of those flecainide patients made it to the next day, but at 1 hour, they had pretty good conversion rates. So pretty scary drug. All right, number 9, Amiodarone versus beta-pace. Beta-pace is kind of interesting because it has beta blocker characteristics, but also class 3 characteristics like Amiodarone. So does that make it better or worse? Well, if you're adding properties that way, if you get a sick patient, it could make them even worse. 665 patients, they looked at an endpoint of cardioversion at 28 days, equivalent at converting before 28 days at 27.1 versus 24.2%. It was basically the same. So they worked the same. But what was interesting in this abstract, recurrences. And after they placed them on these medicines long term, at 74 days was the mean for when the beta-pace patients would have a recurrence of AFib. But it took 487 days for the alternate group, the Amiodarone group. So if you're going to use those 2 medications, certainly Amiodarone appears to be the better choice. But what's interesting as well is the quality of life scores for the patients, regardless what medicines they took, regardless whether they had converted or stayed converted, they weren't any different. So we didn't make the patients feel any better. I think we just were glad that we met our endpoint, and we should really be considering the endpoint of the patient. All right, so what's the best algorithm for electrical cardioversion? So if we're actually going to shock them, how should we do it? Abstract number 10, biphasic energy selection for transthoracic cardioversion of atrial fibrillation, the best atrial fibrillation trial. This is a randomized controlled trial looking at 380 patients, and they talked about escalating versus non-escalating. There are 2 schools of thought here. I mean, do you just want to get in and out and say, I don't want to shock them more than once? Well, then give them the biggest dose that you have, and you're out of there. But if there's family in the room or you don't have great sedating agents, maybe you want to start out on the light side. You know, my philosophy's always been start smaller, I can always give them more. Has anyone ever needed more than 100 joules to get anybody out of a perfusing dysrhythmia? What did you need? And what was it? What was the rhythm? AFib, so you need it for AFib, so 200. They talk about 200 here. How about for you? Okay, so 200. And that's what they're talking about here. You can go 100, 150, 200, then 200 again, or you can just go 200, 200, 200. There's some citations out there that say, hey, go to 360 if you want. But I think you better have them pretty sedated. Those people you have to sedate the family too. I'm telling you what, you have to warn the family. If the family wants to stay in the room, and I'm all for that, we should have nothing to hide. You want to stay for the LP? That's fine. But I'll be on this side of the bed. You have to be on that side of the bed. You can stay for the intubation. You can stay for the code. But if I'm cardioverting your husband, let me explain to you what you're going to see. He'll never know it because he'll be halfway asleep. But you will be traumatized for life. So if you don't want to stay, don't stay. But you've got to warn them ahead of time. This was done with a biphasic Cardioverter defibrillator, and we know that we can reduce the energy levels with this, and we've got energy with the risk of oversimplifying this. It's going both directions, in and out, as opposed to just one big shock going in. So biphasic defibrillators are a little bit better. The first shock, if it was 200 joules, 71% effective, 100 joules, 48% effective, so half of the people had to have another shock. Well, if you're already kind of sleepy anyway, you can zap them pretty quick with another one anyway. And now what's interesting, if your BMI was greater than 25 kilos per meter squared, a little bit more generous than the average patient, then you really favored the larger shock, not a surprise. So 75% with the 200 joules there. So you really have to look at the person and say, yeah, you're getting a little more electricity here. 100 joules just isn't going to get it. So, all right, overall success was equal for both, though. At the end point, you're going to convert them, and it's not a problem. So do whatever you feel most comfortable with. Like I said, it's two different schools of thought, whatever philosophy makes you more comfortable. Abstract 11, atrial fibrillation. They did 360 joules, 56% success rate. Atrial flutter, they found it was a little bit easier. 100 joules, 68%. Now, less than 200 joules in atrial fib, if it was greater than 30 days, if it lasted that long, the atrial fib episode, 6.1% effective if you let it go 180 days, and hopefully it didn't stay in the ED that long, but it dropped down to 2.2% success rate. So the longer atrial fib goes, the longer this pathology continues, the more dilated your right atria gets, and you're not coming out of this thing. And that's why you can shock them all day long, and they might come out of it intermittently, but they're not going to come out of it long term. Abstract 12, two age groups. This is what we talked about with the propofol discussion as well. And the take-home message here is if you're using midazolam, particularly in patients older than 65, you're going to have a significant increased risk of desaturation, 65% versus 19% when you're comparing this to propofol. So if you're going to use something, propofol is probably your safer agent. Abstract 13, best evidence reports, is anticoagulation necessary before cardioversion? I love this abstract. 54 papers were identified in the database that danced around this issue. The unfortunate thing is none of them were relevant to the specific issue. And there were really no data to support why we need to anticoagulate people if they've had atrial fibrillation more than 48 hours minimum and beyond 72 hours. There was nothing. And there was nothing to say, well, once we've cardioverted them, we've got to keep them on anticoagulation for a while. There's no data out there to say that that's the thing we have to do. Although that's currently the standard of practice, you have to be careful deviating from it. But it's good that we're questioning it, and hopefully more definitive data will come out with that. All right, abstract 14 is interesting. This was the pill-in-the-pocket approach. Anytime we can keep somebody home and keep them out of the ED, it might be a good thing. They looked at 210 patients, New England Journal in 2004, less than 12 episodes of AFib in 12 months, so basically an episode a month. They responded previously to either flecainide or to Rhythmol. So if they responded to one of those, you were included in the study. And they were instructed to take a dose within 5 minutes of palpitation onset. You know what atrial fibrillation feels like. When you get it, I guess wait 5 minutes, or go find your pill and go ahead and take it. And if your symptoms haven't resolved or you haven't gotten really tachycardic in 6 to 8 hours, well then they said contact the emergency department. I assume they mean by phone. I mean, I'd send them a letter or something, but I would say probably just go to the emergency department. What are we going to tell them on the phone? If you don't feel right, come in. So at that point, they need to come into the emergency department. They looked at 618 recurrences for 165 patients, but 94% resolved in 6 hours. Interesting concept that those patients who we know have stable intermittent atrial fibrillation, they do very well, and they responded to a specific medicine, why can't they just use that medicine at home and see how they do and come see us if they don't convert? They'll know when they feel better. I think most patients do. Have you ever run into that situation whether you have either electrically cardioverted somebody, or interestingly enough, we run into this all the time, we use an agent for rate control, and then when we bring the rate down, they spontaneously convert. When did they feel better? When the rate came down, or when they popped out of the rhythm, went back to a sinus rhythm? Does anyone ever express a feeling one way or the other to you? My experience has been they know when they're back in sinus rhythm and they feel a lot better. They didn't realize how bad they felt until they got back into the normal rhythm. All right, ED visits and admissions were substantially reduced, of course, so this is a great plan that needs to be considered. All right, is magnesium an effective form of rate control by itself and as an adjunct? Does anyone here like magnesium for anything? Thank you, guys. I love magnesium, but no one's ever going to push this drug from a marketing standpoint because it doesn't cost anything. It's dirt cheap. I liked it with MI. I know the data certainly refutes that at this point. There are lots of different things we can throw at it. Asthma. If you look at the data on asthma, it's probably right up there with Atrovent to the point of someone who is going to need to be intubated of being fairly effective. So it's something we can use and something we need to think about. And here is another option for us. Anyone using MAG for rate control for any tachy atrial dysrhythmia? A few hands there. Every time, or just when they don't respond to something else? Every time. Man, I love the way you think. I do. All right, so let's look at abstracts 15 through 18. 15, meta-analysis of magnesium for acute management of rapid atrial fibrillation. They looked at 8 trials, 476 patients, 1.2 to 5 grams loading dose, a total of 1.2 to 10, so a few people got a few extra doses, versus the controls, which, a little bit loose here, the controls were treated with many different antidysrhythmics, so the controls weren't really controlled very well. Rate control was better than with Verapamil. I just highlighted that one because 61% versus 35%. Verapamil can be a dangerous drug in the wrong hands and with the wrong patients, particularly elderly patients, but it usually brought the rate down pretty well. But in this abstract, they said magnesium did a better job. Conversion was more frequent with magnesium. It's not our goal, but for whatever reason, we know that when we slow that rate down, we're likely in a certain percentage of patients to have them convert their rhythm as well. Time to response was shorter with magnesium, and this is important. The magnesium levels don't matter. We know that sampling mag levels is a waste of time anyway, unless we think they're hypermagnesiemic or really, really low, because they don't really correlate with intracellular levels. If you're somewhere in the huge gray zone, you're not way on one end of the spectrum, that lab test doesn't mean anything. And this abstract 15 tells us the response was irrespective of mag levels, low or high or anything. So don't think that they're going to respond because they're mag deficient. They're going to respond because they respond to mag and its own properties. Abstract 16, randomized controlled trial of mag in addition to usual care. So they looked at 199 stable patients, and they had a heart rate of greater than 120, 2.5 grams over 20 minutes, and then another 2.5 over 2 hours. And what was the usual care 79% of the time? DIG, again, 2005. So I'm surprised to see DIGs there again. Rate control, 65% for MAG versus 24%. But if we're using not a great med for this when we have better ones out there, we're using DIG, I'm not surprised it looks so good. Conversion, 27% versus 12%. Adverse responses, 15% with the MAG versus 5% for usual care, but it was usually minor, like flushing. Yes?
So are you only using MAG in your 72-hour time frame, or are you using it for any rapid?
You're talking about using MAG during that 72-hour time frame. No, we're talking about using MAG for rate control. If we're talking about conversion, these patients, we're just trying to control the rate when we're using rate control agents, Deltazon, beta blockers, these type of things acutely, magnesium also. But we know a certain percentage of those, whether it's the property of the med, I don't think we're sure, or if just we relax things, slow down the heart rate, and let things cool off a bit, do people just spontaneously convert on their own? And I think that's more likely. So then, yeah, the question is, wow, now they converted, what do we need to do with anticoagulation? But I think you get somebody with a new onset of AFib in your department, what's one of your first orders anyway? You're probably anticoagulating them, aren't you? So you've already started the first dose. All right, let's look at abstract 17, MAG versus Deltazon. Only 46 patients. They had atrial fibrillation less than 12 hours. Usual doses given, similar rate control, nobody got significantly hypotensive in either group, and conversion was interesting. 13 out of 23 for the MAG group, 5 out of 23 for Deltazon. So a couple abstracts that are telling us we're getting good rate control with MAG, and we're getting a higher percentage of rhythm conversion too, which isn't a bad side effect. That's a good thing. Abstract 18, MAG versus Amiodarone. Again, doses 5 milligram per kilo, then 10 per kilo over 24 hours for the Amiodarone. MAG, interesting, 37 milligram per kilo, then 25 milligram per kilo per hour following that. They targeted MAG levels. I'm not sure why they did that, but they did nonetheless. But this was way back in 1995. This is 42 critically ill patients with multiple atrial tachydysrhythmias, although the most common was AFib. They used it for multiple rhythms. And neither drug changed the blood pressure. At 2 hours, the patients were in sinus rhythm, 40% for both groups, but at 4 hours, 60% versus 40% favoring MAG. So MAG in those situations actually really favored conversion back to sinus rhythm. I wonder if you dissected these patients, 42 of them in the ICU, how many of them were COPD patients, which might respond a little bit better to MAG, and it might work out better for them. And they had, maybe they had MAT. And so that might have been a good choice for them. Rate decrease in both groups was equivalent. Which is better for rate control, metoprolol or Deltazon? What is your drug of choice? When we're just going to go with rate control, what do you want to use? Everybody using Deltazon pretty much? How about metoprolol? A few. And that's kind of where some of the cardiologists are too. I'm not sure why. Is either a bad choice? No, I think this abstract, if you take a look at it, it's really small numbers, 40 patients, number 19, but there's a slight edge with Deltazon. I said the initial response was quicker, more substantial. 20-minute success rate was 90% versus 80%, but either is fine. You can use either. And if you're really worried about hypotension or an adverse effect, esmolol is a great option, if you have it around. If you don't have it, but that's one reason to keep it around. If you really want to have a very ultra short-acting beta blocker for some of these situations, you can do it. My experience has been, though, even with marginal blood pressures, if you get rate control, either with a calcium channel blocker or with a beta blocker, and you improve diastolic filling time, these blood pressures are going to go up. So sometimes you got this pressure of 95 systolic or 90. Should we really slow the rate down with a calcium channel blocker or a beta blocker? It's a little risky, but you're banking on the fact that when the heart rate comes down to 100, they're going to have much better ejection fraction, much better cardiac output, and the blood pressure will go up. And I bet that happens most of the time. Has anyone experienced that here? A few people? Okay, especially you. Thanks for shaking your head and joining me on that one. A couple people. All right. Is amiodarone really safe in patients with Wolff-Parkinson-White and atrial fibrillation? Now, some people have touted that's the way to go. I tell you, that is a bad thing. If you see atrial fibrillation in a patient who has a known history of Wolff-Parkinson-White, or you saw something in the record or in their previous EKG that indicated it might be Wolff-Parkinson-White and they come in atrial fib, that is a bad thing. That is an imminent death waiting to happen if you don't intervene quickly. So what's the treatment of choice in that situation? It's cardioversion. Just go right to cardioversion. What's interesting, if you look at this urban legend or myth, atrial fibrillation in 10 to 23% of Wolff-Parkinson-White patients, so it's out there. And they did a literature search of pharmacologic treatment of these patients. And a lot of people have said, listen, if you're going to use drugs, amiodarone could be the way to go. But there were no trials of amiodarone at all. Matter of fact, there were 10 case reports of bad things, proarrhythmic events following antidysrhythmics. 7 out of those 10 case reports were with what drug? Amiodarone. The bad things happened. So amiodarone isn't the drug of choice. There is not a drug of choice. That would be a trick question for you. What's the drug of choice for Wolff-Parkinson-White in the context of atrial fibrillation? And electricity is the drug of choice. That's the way you want to go. Procainamide? You could go that direction as well, but I think the situation is they can deteriorate so quickly with atrial fibrillation and Wolff-Parkinson-White that you don't want to run the risk, and so cardioversion is the key. And that's the biggest issue, is making sure you don't give them the opportunity to decompensate. Then using any one of these potential proarrhythmic agents could also run you into complication and issues as well. Procainamide is probably safer than amiodarone, but I would say the key is cardioversion is the way to go. All right, last abstract. What about the use of an ED observation unit strategy for treatment of acute atrial fibrillation? Well, you can apply this like you can anything else with an observation unit. Are they going to get better care or more specific expedited care and get home quicker and save admissions? Yeah, with the right types of cases, going to an observation unit, they certainly will. This abstract said decreased admissions and shorter length of stay. Those who got admitted to the hospital for the same diagnoses, 25 hours. Those in the ED observation unit, 10 hours. Cardioversion, interestingly enough, was done only in 23% of the inpatients, but 51% of the ED observation patients. Yeah, so we're being a little more aggressive with them. And the outcomes at 6 months were identical. So did the patients who got cardioverted, did they do better at 6 months? No. But did they get out of the hospital quicker? Did they do worse? No, they didn't do worse either. We did fine with them. And so cardioversion, with the appropriate procedural sedation, is a great adjunct to what we're doing for these patients in atrial fibrillation. That's all I've got. If you have any questions, let me know. Oh, yeah, right over here.
So I'm just wondering if this is a real difference in standard of care. Because for us, cardioversion, electrical cardioversion, I would say do that once a shift, if not once every 2 shifts. No, I live in an area that has, elderly demographic, but that, and I'm Canadian. But so what I'm hearing from you is you guys admit these patients as a matter of routine?
Why are you looking at me like I have a third eye in the middle of my forehead?
I'm surprised. I
You're right.
very early, they're patients.
We have been taught and trained and told it's rate control. It's rate control. Don't worry about converting it. It's not going to convert anyway. It won't be sustained. Bad things will happen. They have to be anticoagulated. They can't really tell you when their symptoms started. But as we talked about through this half an hour, that probably isn't the case. And you also have to be comfortable doing this because of that history in emergency medicine, particularly our younger physicians, how many of them are comfortable. I talked about the sphincter tone you have to do this. If you're a little bit nervous and haven't done a lot of these, trust me, you're going to write the Deltazon order. You're not going to say, you know what, get some propofol and let's see what we can do. After you've done a few of these, you realize nothing bad happens. Nothing bad happens. You plan for it. You hopefully, make sure it doesn't happen. But it's a rare event for them to go into asystole or something with a synchronized cardioversion in a patient who's sedated. Nothing bad's going to happen from it, but you have to get a comfort level. If you're doing, one a shift, I think you're pretty comfortable. But I'm going to venture to guess that there are a lot of new grads out there that may have not done any in their residency, and certainly out in practice in the first 2 or 3 years haven't done any. And then you think you're going to jump in and say, you know what, I think I'm going to take a risk with this one and do it. And you're also in a lot of U.S. departments who are not doing this. You're the cowboy. Well, no one else does this. And by the way, I am the cowboy without a hat. But they're like, oh, he's going to cardiovert somebody today. Like, yes, we are. But, here, and then we'll come back over here.
Just with the Affirm trial, if they got rhythm control, they took you off warfarin. So that's a big reason why they didn't show any benefit for rhythm control, because they didn't treat them the same otherwise.
Right, and he mentioned with the Affirm trial, hey, if you got rhythm control, you came off the Coumadin, that's a strong argument to get them out of the rhythm. But their arguments, and with the people who like the Affirm trial say, listen, they're not going to stay in it. It doesn't really matter. What about the other complications? And there are two sides of that coin. I'm with you that if we can get anybody off of Coumadin and we can make them feel functionally better, give them better exercise tolerance, they're feeling better, get them out of that rhythm if we can.
I think the argument is that you cardiovert them and you put them on warfarin.
Well, with
they're going to have a high recurrence rate. They're going to do better because they're going to spend longer.
You could do it, and then the big issue there, however, is really just rate control. If you do convert them, great. And yeah, maybe you'll keep them on warfarin, but the thing is, they weren't worried about it. They said it's better. It's a better plan to not convert them. It's a better plan to just plan for a life of atrial fibrillation and control the rate, and we'll anticoagulate you. And that's what we're talking about here, that maybe that isn't true for everybody. And it makes more fun for us because we get to cardiovert people.
Maybe it's because we're close to Canada, down in Seattle, that we cardioverter every week. And the patients can tell you when it started.
Yeah.
And it's 2 days we do it.
Well, absolutely. And what do they end up getting in the hospital anyway once they get a little anticoagulation? Then the cardiologist does it. It's like reducing the dislocated hip. Does the cardiologist really want to do that after a 2-day admission? They're happy if you do it and get it done. They really are.
Yeah, just a question about rate control and monitoring goes back to Rick's talk. Like we've got a lot of patients, significant amount of patients that lock up our short stable because their chronic AF, their rate's about 130. They go off and they get monitored. And I wonder, what are your thoughts on needing to monitor someone while they come down from 130, 120 to that 100? Is there evidence for a bar 100?
So when do you pull the trigger on rate control? Is that what you're saying?
What do you need to monitor? Do you need to monitor a patient at
Oh, gotcha. It depends. If you're using Deltazon, you need to use the bolus. And the key there, in my opinion, and you're not going to get a large enough dose. If you think it's important enough to control the rate, whether you're nervous at 120 or someone else is nervous at 160, we're all nervous at certain points, but certainly 120 and above, I think there's a lot of people would say, I think you probably need some rate control. If you're saying you need rate control, why do you want to wait for the maintenance dose to kick in? So let's start at 12 milligrams an hour and see how long it takes to work. And I'll tell you what, the boluses are a little bit pricey. So always make sure, just a pearl for you, make sure that you order the maintenance dose right at the same time so they hang it at the same time. Otherwise, you end up rebolusing for no good reason. Okay, great, it worked. The rate came down to 90 to 100. So great, now let's order the maintenance drip. Now they get it from pharmacy. Now they mix it. Now the rate's 160 again. Now the bolus that worked before, you get to repeat and charge the patient twice for no good reason. So order them at the same time. Any other questions?